Now both side of the paravesical space is created. So anteriorly three spaces, bilateral paravesical space and uterocervicovesical. Now coming to the lateral and inferior, this is a ureter we recognize, and lateral and inferior to the ureter is a interiliac artery. Between the interiliac artery and the ureter is a get to the pararectal space, and here we can identify the inferior hypogastric nerve. So to identify inferior hypogastric nerve, here is a big value, and then you can lateralize the inferior hypogastric nerve till its entry into the bladder. So the mirror dissection is carried out on a left side. Here we see the ureter. Again, between the interiliac artery and the ureter is a inferior hypogastric nerve. This is the space of the Letsko and Okabayashi space. That is a medial pararectal space. So 5 spaces are opened up. 6 avascular, 6th is your rectovaginal. You need to work just above the fat of the rectum, and the spaces are easily openable. That means the case is operable. So throughout the surgery, I hadn't taken any vessels. So if somewhere I need to declare the patient as an inoperable without compromising the blood supply to the uterus, it can be declared inoperable. So that helps a lot. Oxygenated tissue can receive the radiation very well. Now coming to the bilateral ureteric tunnel dissections, these are the steps. We make a window underneath the intact uterine artery, rotating the uterine artery from distal to proximal. That helps a lot in dissection of vesico-uterine ligament, and teasing on a medial wall of the ureter and superior wall of the ureter. That helps a ureteric tunnel dissection, and taking the ventral parametrium. This is a stepwise technical description of the ureteric dissection in laparoscopic radical hysterectomy. So here, these are the steps. So I have made window underneath the intact uterine artery, and rotating this uterine artery from distal to proximal. Through the window, we can see the ureter, and here is a anterior. We can see the vesico-uterine ligament that carries cervico-vesical artery and the vein, taking care of it, teasing the medial wall of the ureter and superior wall of the ureter that separate. This is the knee joint of the ureter. And now once you see that, you need to work just inferior to the ureter, and that separates the ureter from the knee joint, and this is entering of the ureter into the bladder. Now here you can see the beautiful relation between the intact uterine artery and ureter. So the divergent force of the grasper that keeps away the ureter, you can see that open grasper, safeguard the ureter, take the ventral parametrium toward the specimen. So taking the circumferential parametrium is really important in case of the carcinoma of the cervix. This is a beautiful relation between the intact uterine artery and the ureter. Now, application of the GI endostapler in gynec oncology. So we use the enclosed colpotomy with the GI endostapler in case of the cervical malignancy and carcinoma of the endometrium to prevent the spillage of the tumor cells. At the time of the colpotomy, all the surgery is completed, lymphadenectomy done, 6 avascular space and everything is done. Applied the GI endostapler, and here you can see the completely specimen is like a bag itself. Now opening this vagina again, at that time I'm not using harmonic scalpel, I'm using the ligature, or you can use the cold scissor as well. So that prevents the spillage. And the vagina is full of the betadine. Betadine itself is a tumoricidal, so it helps. So this is a published 2 times vaginal closure before colpotomy to prevent tumor spillage. And one more prospective study, use of the endostapler is done. Now coming to the lymphadenectomy, opening of the peritoneum over the right common iliac artery. This is an inferior mesenteric artery. Here you can see on a left side of the common iliac artery we can see, and lateral to that would be the left side of the ureter. Now here, this is the right ureter working underneath the ureter that will expose the precaval nodes here. This is a part of the inferior vena cava that is lateral to the right common iliac artery. So you just follow perinodal tissue, the vessels are clearly visible, and you need to follow the vessels. So this is bifurcation of the aorta. Presacral lymph nodes are taken care with the tip of the harmonic scalpel here. And proceeding from here to the pelvic lymphadenectomy, the lateral margin is the right side of genitofemoral nerve, and 360-degree to the extrailiac artery, extrailiac vein, obturator nerve, interiliac artery. We need to remove all the fibrofatty tissue in case of the cervical malignancy. From lateral side, we can see here, this is the obturator nerve, proximal part of it. Now flipping all the lymph nodes from the lateral wall to the superior wall and then medially. Starting again from the bifurcation of the common iliac artery, that is external and interiliac artery. Here you can see that. And a medial wall of the extrailiac vein. And we are reaching up to the arcuate ridge of the ilium. There's one more node on the lateral wall of the extrailiac artery and the vein junction. And this is the arcuate ridge of the ilium, where we reach to remove the obturator node. And here we can see the bright shining property of the obturator nerve. So this is done. So both sides of the pelvic lymphadenectomy, presacral lymphadenectomy is done. Now coming to the carcinoma of the endometrium. So this is the first study published from the India Surgical Pathological Outcome Carcinoma of the endometrium of the 88 cases, and we are now coming with the 250 cases publication. So this is a case. She had endometriosis, she had a Lynch syndrome positive, and she had a double malignancy, CA endometrium and CA in ascending colon. So this is a common finding we can see in many cases of the CA endometrium. Endometriosis that creates the infertility, and that becomes a factor for the malignancy also. Not only this one, but she had a Lynch syndrome positive. So this is the endometriosis way, working on a medial wall of the ureter and removing all the nodules in case of the CA endometrium is mandatory, because this can also have a metastasis. So working on a pararectal space. Now the central disease, separating it from the posterior cervix and vagina. Don't forget to remove all the nodules. Push all the nodules toward the specimen. See that fat is affected, that is moved toward the specimen. And the radical hysterectomy is carried out. I'm just making it, already I demonstrated the radical. And the pelvic lymphadenectomy done on both sides. Okay. And this is inferior hypogastric now. So this is a radical. Finally, it is done with the lymphadenectomy and everything. Now hemicolectomy. Here you can see the in ascending column, there is a 4 centimeter disease, not only in the mucosa. So plan to do right side hemicolectomy. For that, lateral to medial and mobilization of the hepatic flexure and taking the artery. And here, now for linear stapler fired over the ilium and linear stapler over the transverse colon. Then remove all the mesentery, because this was the case of the malignancy. Then side by side anastomosis, ilium to transverse colon carried out with the linear stapler blue cartridge, and the enterotomy closed with the V-lock 30. Now this enterotomy is closed. Okay. So this was a hemicolectomy. Now omental biopsy, that all we know. Para-aortic lymphadenectomy in this case was mandatory. So the incision over the right common iliac artery, peritoneum, incise over the aorta and IVC. Both sides of the ureter will be safeguarded, and margins are cleared first. We this left side of the ureter here. This right left side of the psoas muscle is visible here, starting from left common iliac artery. You can appreciate the lateral cutaneous nerve. We need to take care of the lateral cutaneous nerve, and the lumbar artery would be here. And from here, we start over the inferior mesenteric artery. You just let me know if the time is over. I'll stop it somewhere. And from the bifurcation, all the nodes, this is the bifurcation of the aorta. So this is the left lateral wall of the aorta and the left ureter. You can see that. Now we reach up to the proximal, that is a left renal vein, that is our upper margin. And now started from the aortocaval region. Don't give too much traction and the counter traction.
Okay, I see the hormone.
This is the right gonadal artery that is clipped. And here, this is left renal vein. Pork node is removed here. Okay, so this is after removing all the para-aortic lymph nodes, this is a view, left renal vein draining into the
RBC. Disconnected.
Left side of the lateral cutaneous nerve, psoas muscle. And this is a specimen of the ascending colon, which had a 4 centimeter disease. And now genetic test was performed, and it was a confirmed Lynch syndrome 2 positive, and MS1 as gene defect was found positive. This is also published in a journal, that is synchronized carcinoma of endometrium of the uterus along with the ascending colon. Advanced case of the carcinoma of the endometrium, ignored disease, and what happens? That tumor busted from the serosa and invaded into the descending array, sigmoid colon. And here you can see the first view. Then we did surgery with the single specimen removal. So we did a radical hysterectomy. We didn't try to separate the sigmoid colon from the specimen. Following the all oncological principle, opening of the 6 avascular spaces and radical hysterectomy done. Then here, Michael is taken care. Okay, so now radical hysterectomy done, but not separated the sigmoid colon. And after that, this is the proximal margin of the colon and a retrorectal space created. Both sides of the now spared. And here, now, sulfatomy carried out, and the rectum is open here. Use of the GI endostapler for the distal end of the rectum. Proximally sigmoid colon divided here. IMA taken care with the clips. And so this is a single specimen that contains uterus radically surgery and along with the part of the sigmoid colon and the rectum which was involved. So that was kept in endobags. Lymphadenectomy already demonstrated. After lymphadenectomy, this is about the presacral nodes. Okay. So LAR is done along with the radical hysterectomy. Carcinoma of the ovary. We go through the video that this is the first endo view that we can see the peritoneum is totally studied with the disease and omentum. This is appendix and everything. So we started along with the ascites. We started with the peritonectomy. All the disease peritoneum, almost the peritoneum is removed, and along with that radical done. And here we start This kind of a surgery takes very good time to operate because it's time-consuming surgery, this one. The single specimen, like the parachute specimen, is to be removed along with the peritoneum. Now, the bladder peritoneum is going to be separated in such a way that the bladder will mobilize from the cervix after reflecting the peritoneum of the bladder. Here, this is a inflated bladder and it is separated. IPL is taken care. Now coming to the colpotomy. So, pelvis peritonectomy done. Now upper part of the abdomen peritonectomy we are doing along with the falciparum ligament and everything is removed along with the omentectomy. Okay. Now after chemotherapy, redo-scopy for the single isolated recurrence at the rectum region. Here you can see the view that there is no peritoneal disease. The first look of the surgery was different, and after surgery and the chemotherapy, this is all fibrosis. We can see that we work on all this area, and there is a isolated single recurrence we can see in a little wall of the rectum, and that was excised, and this patient is absolutely fine. So the treatment plan for the ovarian malignancy is that operation, chemotherapy, and if you need again, you need to redo laparoscopy and follow the chemotherapy principle. Special case scenario: 19-year-old girl had a germ cell ovarian malignancy. She received 4 cycles of the chemotherapy, but she had a para-aortic region nodes, and that was a 10 centimeter node, and I did this surgery, completed, and this patient is out of the malignancy now. And it is a low malignant, but she had recurrence here in the para-aortic region. So all the nodes moved from the para-aortic and precaval to the left little wall of the aorta. So we started first to define all these margins. This is the second part of the duodenum. Here we can see, and we check about the integrity of the duodenum. Okay, so this was previously operated, and this is all fibrosis area. So we need to work millimeter by millimeter by understanding all these things. And the left renal vein is exposed. And this is a lower end at the level of the bifurcation. Left side of the ureter, we will see the fibrosis again. We are working over that fibrosis, and now started from the unaffected area that was not touched, and this is a mobilization from the precaval nodes to the aorta region. That's a left renal vein. We can see that. Now, after that, the main job starts from central to the left side. So here we cannot get the loose areolar tissue which are helpful on an affected area. This is a area where work was not done. This is a loose areolar tissue, is a friendly here, right side precaval nodes. So this is a removed from the precaval. Aortocaval nodes taken care. All the aortocaval. Here we can see we reach up to the left renal vein. So this part of the lymph node is done. Now the complexity of the surgery starts from the left side. Left lateral wall of the aorta. And this is a node, this is a fibrous, this is chemotherapy and previously operated area. And now it is exposed by working millimeter by millimeter. With the use of the divergent force, inner fibrosis to the ureter, this is here you can see the complexity that left lateral wall.
Sir, your voice is not audible. Excuse me, sir. Your voice is not audible now. And the time is up.
Dr. Deepak, is the volume not okay from your side?
मेरे ओके उधर से नहीं है उधर से भी आ रही पीछे से नहीं from their side.
This is a distal.
Yes.
Final stroke would be here, and that's a final stroke, and it is removed. And this patient is absolutely fine. She is under my follow-up since 3 years, and she is out of this thing. So this is the working in a fibrosed area.
Excellent videos.
Now coming to the laparoscopic parametrectomy, this is a common scenario. What we see that patient underwent hysterectomy, and finally we get the report of the CA cervix or the CA endometrium. And in that case, to avoid, this is also published in your Chandigarh doctor, Dr. Hina Chawla published this radical parametrectomy in 2014 or 15, I think. So again, the same principle. There is no uterus, but opening the 6 vascular spaces separating the rectum of the posterior vagina, bladder separation from the anterior vagina, laterally, pararectal and the paravesical space, and so 4 spaces are opened up, taking the uterine artery at the origin, doing the tunnel dissection, identifying the parametrium and the paracolpus, and pelvic lymphadenectomy. So we can, in many cases of the cervical malignancy, we can divide the radiation if she undergoes this surgery. And for the CA endometrium, we can do the comprehensive surgical staging. Now, this is a colpotomy, and the IPL on the left side is done, proceeding for the colpotomy here. And this is the specimen, and lymphadenectomy and the parametrectomy is done. So this is laparoscopic radical parametrectomy, an alternative for the cervical endometrial malignancy after hysterectomy. This was published by Dr. Hina Chawla. Thank you, everyone.
Thank you, Dr. Deepak, for the excellent presentation, excellent videos.
Thank you, everyone.